episode of RetFix and Chill. Today we're talking scleral buckles. I'm Nitish Mehta. I'm on staff at NYU.
Mike Andrioli from Northwestern Medicine.
And Sarwar Zahid from Queens, New York.
David Chu from Wills-Eye Hospital in Philadelphia.
And Mira Sivalingam, also at Wills-Eye Hospital in Philadelphia.
Cool. All right, so let's get started. And today we're having a special called Only Bands. We're going to be talking about scleral buckling in all of its various forms. I know I can't say that straight. I couldn't say that straight. But you get the point. We're going to show some cases, and it's going to be all primary buckles, and hopefully we'll learn a couple different strategies, why people did what they did, choice of like different elements, any tips and tricks that you've picked up along your training. So we're going to go around the room, show a picture, and kind of describe the case, and then kind of talk about what certain options are. So David, you want to go first?
Yep, absolutely. Okay, all right, so I want to share this case here. It is a patient with a retinal dialysis, inferior temporal, very classic case of a 16-year-old boy who got elbowed during a game of basketball. Otherwise, normal individual, normal boy, no past medical history, macula off, and has a fairly acute injuries. It's only been, within weeks since the injury, and count fingers, vision at 3 feet, and as is typical, it's a phakic patient with no PVD. There's a lot of different ways to skin a cat, and this is, I think, a prototypical case of exactly that.
The first thing that jumps to my mind is, do you encircle or not, and kind of what are the thought process behind that? So Mike, what do you think in this case about your different options here?
Yeah, from what I see there, it's small enough where I think you could get away with segmental, although in my hands, I really typically do a encircling. You don't have to imbricate very much on a typical dialysis, so there's not really too much downside in my experience doing encircling. So I think that's probably what I do, a 41 band encircling.
Yeah, I think that's a great point. Yeah, I like the idea of encircling here. One thing that I've gotten into this sort of habit of doing is adding grooved elements, because getting that extra kick from the grooved element, because in this case you don't really need to drain, and sometimes some of these cases can be tough to drain. So I would consider, I would also do a 41 band with a 287 wide groove, which is a nice element that fits, and you would only need to do it in that infratemporal quadrant. And the nice thing about the thing that people complain about with these larger elements is that you have to get further posteriorly, and that's a pretty long pass and can be annoying to deal with. The nice thing about having the encircling band is you don't necessarily have to suture the element; you can just suture the band, and you have the groove holding the element together. And I think that extra posterior kick, allow you to have a lower height for your buckle.
And so for that grooved element 287, are you encircling using a 240 band, or are you using the wide groove with the 41 band?
I'm doing a wide groove. If I'm encircling, I like having the extra 1.5 millimeters or millimeter of support. I probably would have it just cover the infratemporal quadrant, not and it won't even be in this situation. I'd probably put the suture in the infratemporal quadrant, closer to the inferior rectus, and basically have the it would probably be 12 millimeters of coverage in the infratemporal quadrant. And it doesn't add too many steps. So you just have to be careful where you put your stitch or your tunnel, so that you have room to slide it. I just slide it in at the end. It's mostly about the sizing, and I think it helps with having a lower level of imbrication.
So when you put that grooved element, do you size it to the size of the break, or the size of one quadrant?
I actually size it to the size of the break.
Yeah.
Yeah. Okay. Or like I try to do clock hours, so I've been told like 3 to 4 millimeters is 1 clock hour. So if you want to just kind of multiply that by how large you think the break is. But one thing I want to question about this is that by definition, dialysis is a fairly anterior pathology, right? So like, why do you need a large element with a lot of posterior kick? What benefit is that serving in this case?
He's going to show a successful outcome, because I think this one, pretty much anything you throw at it's probably going to work in this patient. But yeah, show us what you did.
A lot of this in this particular case goes down to your preferences. So this is a chandelier buckle, and the height of the retinal detachment looks, based on this surgical video and this view, it looks like it's not very much, but it is a sizable amount of fluid. It really is, and the break is probably bigger than what you would really think that this is more than 2 clock hours, probably closer to like a 3 clock hour type of break. And so I'll show you what the band is, but we're draining. This is an inferior temporal detachment, and typically with such a large detachment, with such a large break, substantial amount of fluid, I do like to drain the inferior detachments. And so we're using a Hanscom needle, a guarded 25 gauge needle with a curved extent and a bevel so that it bevels facing outwards towards the wall of the eye, with pressure on the globe in order to force the subretinal fluid out after that completion of the drain. So this is talk about what elements I actually used. So, I found it interesting that there's somebody else like me who likes to use scleral buckling elements, not encircling only. So I did use a 276 asymmetric tire and a 240 band. It carries a 240 band within its groove, and that's my go-to surgery in a patient where I think things are more than what would be held by just a encircling band alone, or if it was a case that could have been treated with encircling alone, I would have needed a fairly high encircling. And this is essentially a way to derate how high of an encircling band I would need to do. But I agree with most people that by definition with dialysis and such a young child, it most likely would work with almost any type of surgery.
Yeah, I do a fair amount of, like I've told these guys before, 220s as kind of additional element. I tend to put a full quadrant. I'm usually not like putting 1 clock hour of an additional element. I'll usually cover the full quadrant if there's an area I'm worried about.
Yeah, so with 276 tires being asymmetric, there's a thicker side and then there's a thinner side. And typical classic way of using a 276 is to put the thicker side more posteriorly to support the posterior aspect of tears or atrophic holes or things like that. But, as people had mentioned over here, the dialysis is an anterior pathology. And so one of the things I do for dialysis, if I do use the asymmetric tires, I put the thicker side more anterior to support where the break is. That's probably the only variation that I do here. And that element is so wide that, in terms of where to place the buckle, it kind of really covers it for a dialysis. It really covers it for almost all standard retinal detachments, unless you're experiencing something where there's a very abnormal posterior vitreous space, or you're dealing with a schisis retinal detachment with a very posterior break. Almost any other type of pathology, usually that kind of a 7mm extent of an element is going to cover it.
Can you talk to us about the choice of using a chandelier? Is that more of a training utility, or do you like just doing it in terms of practicality?
I like it from both. So we are a training institution for us, and it's great being able to see and operate together. It is more ergonomic, and so there's not the bending over as much that you would have to do with an indirect. The fellows are all very used to vitrectomy, and driving the eye through the ports and the instrumentation is really beneficial. You'll notice if you look at the video again that I like to put the chandelier illumination. I use valved cannulas. I don't use the default valveless cannula that comes with the Alcon chandelier pack.
Yeah.
And so with the valve, you have stability. You don't have a risk of vitreous prolapse. And I put them superior temporal and superior nasal, the same places you would put your vitrectomy ports, which makes it, again, convenient for fellows. They know how to drive the eye with instruments in those locations. And I split my time with chandelier buckle versus standard scleral buckle. And I tend to actually use chandelier these days in the latter half of the academic year. And then I use standard scleral buckle in the beginning half of the academic.
Can you talk a little bit briefly about your drainage choice? Because I know that's something that many fellows mention that they have a little anxiety with. They're worried about bleeding.
Yeah, I'm somebody who is more pro drainage, and I like it because the biggest thing is that it helps me normalize the intraocular pressure, and I'm very nervous and I'm very cautious about leaving an eye with a supraphysiologic intraocular pressure. So that really, draining gives me the room for me to tighten the buckle to the appropriate extent. And that's, I think, the biggest reason why I am pro draining. I do like to drain most inferior buckles. And again, anytime I feel like I need, that extra room. As far as the drainage method, I've done really all three of the most common, cut down and cautery, and then, a puncture site. I do a straight drainage, without any pre-cauterization of the scleral bed. And that's probably what I typically do these days when I don't do a chandelier buckle. And then also using the drainage needle. The benefit of the drainage needle in this case, and I think a lot of individuals know this, is there probably does lead to a more complete drainage. And the reason is because the speed at which it drains is a lot slower. There's a lot greater resistance because the fluid has to pass through the entire length of the needle rather than just exiting the eye through an incision of the same size. And that basically prevents local collapse and reattachment of the retina, which then tamponades that drainage site. It allows for the flow of the fluid through the entirety of the extent of the retinal detachment. And also the bevel is such that basically the tip of the needle tense up the retina and allows for, again, continued flow and communication of the local drainage site versus the rest of the retinal detachment. And one last benefit is that it separates the act of the incision being created and also the sudden collapse or loss of the intraocular pressure, which I think, at least in theory, reduces the chance of hemorrhage. Because the idea is, it's just like general surgery and traumas. The moment which a patient bleeds after they get stabbed is when the knife is pulled out, not at the time which the knife goes in. So you keep that blade inside of the eye. And by the time you are done with all of your drainage and you very greatly push on the eye to elevate the IOP temporarily, then you would withdraw that needle and you can really separate, again, the drop in intraocular pressure and the removal of the blade, which is not possible with the other drainage methods.
Love that analogy.
Yeah, that was beautiful. The drainage is being done, you're pulling on a syringe, or do you connect it up to some sort of aspiration?
So actually, yeah, so I actually just pull the plunger out of the needle, and so it's actually free air that is draining through, but it happens pretty slowly. There's a lot of resistance. This fluid is usually very thick. Again, it's a 25 gauge needle for this prepackaged Tansum needle, but if you fashion your own, obviously you have a choice in selection, and many people do that. It's kind of how the whole thing evolved here. That guard, as you guys know, is actually the sleeve, and you just slip it on, pre-trimmed to the right size. And so, that's typically the way that I do it. And that helps, again, so that I have a hand free to push on the eye. And that's one of the good things about the chandelier is that you're able to control aspects of the eye a little bit more easily. So the chandelier is not being held by your hand. You just bend the gooseneck and it illuminates the eye. And then the ReSight lens or wide field of visualization is there. You don't need a hand for that. So you have one hand for the needle and one hand to really push in the eye, which allows you to complete the case without the need for potentially any assistance to help push on the eyeball or anything else. And you still have complete control of the eyeball in terms of control of the IOP and everything else.
Vortex, just one quick point, makes this external drainage and depression and drainage device where you could basically, it's sort of like a flex loop. It guides in a needle. It's really nice. One thing that I've noticed actually is after, because I usually have the IOP up with the buckle tightened. And then after I come out with the needle, you still get some passive drainage through that tract for a period of time until it gets to a physiological level. So it's nice to see that as well.
Awesome.
Okay, so we'll continue on to a second case over here. This is a 51-year-old female, and there's some chronicity to this case. She's lost vision for 1 month, and she reports that, quote, half the vision is gone. She's still seeing 20/30, so the fovea is barely involved here. And you can also see in the wide field photo, there's already the development of some amount of subretinal bands over here. But this is still, solvable by vitrectomy alone. There's no PVD. She's by scleral buckle alone. There's no PVD. She's phakic, and the source of the detachments are inferior atrophic holes and lattice. And I'm showing a different flavor of what can be done, as compared to the first case. But I'm happy to talk about what I did, or happy to go around the room and what would you guys do, I guess.
Chronic appearing inferior detachments, I prefer to have a buckle inferiorly regardless. I would try to primary buckle this, probably 240 with a 220 element inferiorly. And then if I wanted to do a vitrectomy for some other reason, I would be putting at least an inferior segmental, if not an encircling band. I personally have had better experience with inferior support when it's a chronic inferior detachment.
Mm-hmm.
Yeah, I mean, I would definitely try buckling this at first, depending on, where the pathology is. Usually with a straight buckle, I'll start with a 42 band. If I feel like they need, wider support, sometimes I use a 40/50, that 5 mm band. It's pretty wide. And I like it in people who have a lot of pathology. But I would definitely start out with a buckle. And then if, it's not flattening, if it fails, then go to vitrectomy.
I'll just play our surgical video here. Again, this is another chandelier scleral buckle, and I think in this case I go over a little bit more about the steps of chandelier buckle for myself anyway. And we had mentioned that I like to use the valve cannulas, and that just makes it more convenient. So it was a supranasal break, and we're evacuating the subretinal fluid. I do think that in this case, when there's chronic detachment, especially if there's a large extent of the detachment inferiorly, I like to drain and remove that subretinal fluid. It gives me the opportunity to tighten that buckle up appropriately. And I did place a C-Therafate gas bubble. It's probably about 0.3 or 0.35 cc's in terms of the gas bubble, because the location of the break is superiorly. And I tighten the buckle up, and I also added AC paracentesis. I'm just very careful about normalizing the intraocular pressure after scleral buckle. And what this segment of the video is showing is that there really needs to be a lot of care and delicate management of closure of these to minimize any reflux of vitreous out. And one of the keys is how everything comes together as a package. Is that if you have a normal intraocular pressure, there's not a very prominent amount of reflux of the vitreous. But if you leave a very high intraocular pressure, then the vitreous is going to prolapse very avidly, and that's going to require trimming with Wexel and Westcott scissors and things of that nature, which is not as desirable. If you inject your gas through one of those trocars, because the extent of the trocar is very short, it just barely peeks into the eye as designed. When you inject it, it always forms a beautiful single gas bubble, which is a nice perk if you do the chandelier vitrectomy. The thing I didn't mention is that the element I use is a 42 band. 42 band with no elements.
I'm the same way about IOP, man. I don't play with IOP.
Chandelier buckle in a teaching setting is really nice because you can really show your fellow, what cryo is supposed to look like. You can visualize the pathology really nicely. So, it's a really nice teaching tool.
Yeah, I definitely think that the insertion of the needle requires almost a small leap of faith. There's two ways to do it. You can insert it without necessarily visualizing directly, even though you got the chandelier right there. And that's basically the same thing as anyone is doing when they insert a needle during a standard scleral buckle. It is a blind procedure based on what you know. You can pre-mark, and that is definitely adequate as well. So that's one way to do it. You could also put the needle and use the needle's side, almost like a scleral depressor. And then while you're visualizing, you can indent the globe and you can confirm again as a final gut check. And I don't typically do that because, you should know where you're going to place that needle. It's how you normally do a scleral buckle. So that's generally very good.
There is one potential benefit to the Vortex instrument. It basically is like a scleral depressor shape and has the needle that retracts, but I actually haven't used it. I have a couple of samples that I've been meaning to use on like crazy pneumatic patients, but I haven't used it in a scleral buckle setting.
Does anybody here have any experience with the smaller meridianal implants, like the 103, 16, 112? Because when you have a very focal pathology that might be slightly posterior, like in this case, I feel like just slipping that in for that little push just seemed to give you that added level of security.
Yeah, I definitely use those from time to time as well. I think that it is really case dependent, and it straddles that difference between if I could tighten my band a little bit more encircling only versus if I think it really requires some real kick, then I add an element. It's just finding that little like perfect Goldilocks zone where you can get away with a small meridional element. I do sometimes do that. I will say that when you use those meridional those elements, they vary in size, but they're usually pretty small. They're usually about the size of a tear or a hole. And so if you have a singular defect in the retina, I think that's appropriate. But if you are dealing with an eye with multiple grouped adjacent atrophic holes, then you are probably not going to want to employ that.
Two things. One, you did this on a 51-year-old. And I think that's important, because some people stay phakic for a very, very long time. And, even if you think that they're over the age of 30, does not mean that you can't buckle these patients. I think it's great that a group of like young attendings like ourselves are still trying to learn primary buckle and use them on older and older patients. And the other thing that I just wanted to seems like is sort of what we're learning on this chat is that, you want to learn your encircling, and you want to learn your encircling with one other extra push. And it doesn't necessarily matter which one that is you choose, but find that technique that works in your hands and add that to your armamentarium, because you can see how valuable it is on these cases. Let's talk some more. Maybe let's have Mira show.
Yeah, so this was a 27-year-old female who actually came in through the Wills Eye emergency room with a corneal ulcer in her left eye and was incidentally found to have, an asymptomatic chronic appearing retinal detachment in the right eye. You can see there's a demarcation line here supranasally. And she basically the pathology was really inferior. So she had lattice with multiple atrophic holes inferiorly. I don't know if it comes through with this picture, but she did have a kind of round schisis cavity inferiorly. Subretinal fluid is kind of, approaching the fovea, but she's still 20/20. So, just curious as to what you guys would do, how you would approach this. Obviously, she's young. There's no PVD.
I feel like the first question that you're going to ask is, should we do surgery in this asymptomatic demarcated retinal detachment? I think for me, the answer is probably yes, based on this photo. It is involving the fovea, and you'll never be able to laser or augment that demarcation in the fovea, not without some serious side effects. And so that's not recommended. And I think the only other choice to make this thing stable is surgery.
I think you could try minimize eye movement, but I wouldn't be too optimistic about it. But I'd probably go to surgery as well.
How do you guys, with these chronic detachments in terms of timing? So, one thought that was going through my mind was she had a pretty bad central corneal ulcer in her left eye. I'm always nervous about taking someone to surgery when they have, something active going on in the other eye. It's a chronic detachment. She's been asymptomatic. What would you guys do in terms of timing?
I would wait till the corneal ulcer resolved. Yeah.
Yeah, I don't think there's an emergency.
I feel like you could just ask her to buckle herself for like 2 weeks, and then the detachment would be resolved.
Yeah, great. Just put your thumb in there.
Yeah.
So I took her, we let her stabilize with her corneal ulcer. We got her off fortifieds. Cornea got her off fortifieds. And then I took her to surgery. So I did a straight buckle for her, 42 band. Her pathology was, not extensive, mostly inferior pathology, not super posterior. So I did a 42, actually, sorry, we did a 5 millimeter band, so 40/50 band. And then, so the way I like to drain is I do a focal cut down. So I'll take a 57 blade, make a linear scleral incision, carefully dissecting down to the level of the choroid. And then I do like to take external cautery to the bed of the choroid to minimize the risk of bleeding. And then I'll take either a 30 gauge needle or a 27 gauge needle on like a TB syringe, poke through just through like the tip of the needle. You don't need to go in very far, especially this is a fairly shallow detachment. So obviously you don't want to go in too far, and really you'll see that drainage pretty immediately. When I'm deciding where to drain, I do like to sometimes if the fluid is more focal in a certain meridian, I do like to mark. So I'll visualize with a scleral depressor and then make a nice mark on the sclera just for safety. You can never be too safe. And then, you get the nice drainage. After I see that subretinal fluid, through the sclerotomy site, what I'll do is I'll take, a bunch of Q-tips and kind of massage the area. I try to keep the flow of the subretinal fluid going because sometimes it'll get plugged with tissue. So really try to keep that flow of fluid going as much as I can. In these chronic detachments, like David was saying before, a lot of times it's, the fluid's really thick. So I do give it time, it's, I'll sit there and wait until I'm not getting any flow. Sometimes, it's a couple minutes, but you want to get a really good drainage.
Samira, I'm wondering how do you adjust, or how do you judge the height of the scleral buckle? Do you eyeball it after you finish your drainage, or do you,
Yep. So I always, after, I look. So what I do is I put the buckle on. I usually, tighten the buckle down, not to its final height, but like we were saying before, I do like to look in the attached retina. It's kind of, for me, it's hard to drain when the buckle is fully tightened, just because I'm usually draining around. I like to drain around the area right under the buckle so that you have that extra support and tamponade in case you get any bleeding. And then I will usually do the final buckle height adjustment after the drainage. I think you do have to be careful, because if you get a lot of drainage, I think you are at the risk of over tightening the buckle. So I'm cognizant of that. If the eye is pretty soft, sometimes, I won't tighten the buckle. I'll just tighten the buckle so it's flush to the sclera, and you'd be surprised. You get a lot of indentation just from making it flush to the sclera, especially if you got a good drainage and the eye is pretty soft.
Do you try to, when you choose the place for drainage, do you try to avoid where the retinal break is because you're afraid of just having that communication from the vitreous, or do you not really care?
Yeah, I don't usually, ideally, I usually try to aim where the subretinal fluid is the most and the retina is the most elevated. I don't like going right where the break is. Because of what you said, the communication to the vitreous, but B, theoretically you could get, that retina could flap down and plug the area where you're draining, and you're not going to get ideal drainage.
Yeah, just check when all those three coincide, though.
Yeah.
I think for me, this is a case where it'd be extra apt to do drainage just because it's a chronic detachment, and so it's going to be the thickest fluid out of any detachment, and that means it's just less likely that the apposition from a non-drainage buckle, especially for an inferior detachment, I think with an inferior break, I think those are the most likely situations where you're going to have a failure and persistent non-contact with the retina.
Yeah, I think if you don't drain in this situation, like, that fluid's going to be there for months. Even, I haven't seen patients who've had subretinal fluid for over a year after they're buckled. So, in addition, she had a small schisis cavity at like 6 o'clock. That I was a little bit worried about, that it wouldn't, allow the retina to flatten out, but it actually, after drainage, it actually flattened out pretty nicely. It wasn't totally flat, but, post-operatively, it's slowly flattening. So she's done really well.
Nice. It's great.
Like devil's advocate a little bit on the drainage part, just for discussion purposes. I don't think it matters if you drain this patient. You'd be watching it and annoyed for a year to year and a half looking at the fluid, but she's asymptomatic. I don't think she would care in the end. I don't think it would change the outcome personally. And I've become a little bit more of a minimalist in terms of drainage over the years. I mentioned offline that I used to do external needle drainage under indirect visualization. Now I just partially guard a 5/0 nylon needle I'm using anyway and stab in. And I just like to get some anterior drainage in the area that I'm buckling. I don't really care how posterior I get the vast majority of the time. I'm just trying to reoppose the retina a little bit easier and maybe get some of that chronic fluid out. But I sometimes don't want a full drainage when it's very bullous. I don't want to drop the IOP a ton. I don't want to risk, the eye collapsing, hemorrhage, things like that, when I don't think it actually changes the outcome. And maybe there's even some issues with retinal displacement by, being more aggressive in your drainage. So I think you could definitely go either way in a lot of these cases. It's, I think, more based on what we were trained doing, to be honest.
Yeah. I think also one theme that's coming up here is the more you do, the more likely you are to have a confusion in the final buckle height, right? So like the amount of steps that you put, the amount of work that you're doing, gas in the eye, drain, non-drain, it's just going to continue to add variables that will make your final prediction difficult.
Yeah, I totally echo what you said, Mike, which is that as I've gone on doing this, there's a time when I first started that I would mark the breaks, and I would use that for estimation of the height. And I could find myself, I don't do that anymore. I don't find myself needing to mark it. I find myself just from the exam, I have a good sense of where the buckle needs to go. I have limited how much I use the Hanscom needle. Just, it is also convenient. I actually use a suture needle as well and stab in directly. I totally agree. I see that progression in myself as well in terms of just less, and the efficiency is better and everything.
I love that comment about just draining the area around the break so you get apposition there, because then, if you've done cryo, you have, at least adhesion there, and then you let the RPE do its work. The only problem is sometimes if it's chronic, then you're waiting a long time, but at least the retina's reattached. If it's flat at the breaks, then you've done your job. And there's,
Question for you
people
guys:
don't call it.
does the macula status, theoretically, if she was, fluid was, closer to the fovea, would you guys be more likely to drain in that case, because you want that subretinal fluid to flatten out a little bit faster so that we can get the macula flat. Or
I guess it depends to me actually on the height of the inferior pathology. So like if I put the buckle on and any element on and I take a look and that thing's still floating, that's actually my decision on when to train, not less so what's actually happening in the macula.
Yeah, that's kind of how I do it too. But like you said, if this was like, you had a fair amount of fluid through the fovea, I would be much more inclined to drain and want to drain a bit more just because it's going to be there so long. Although you guys have probably experienced it just how I have. Those patients do surprisingly well when they've had fluid for a year and a half under their fovea and they're still like 20, 25 plus. It's kind of surprising to me how well they can do in the end sometimes.
Cool. Well, that was an awesome case. And I think we've heard a lot of differing opinions that kind of come together, just in the final outcome is we're all trying to get these patients flat, attached, seeing well with the lowest number of complications. And you can see how there are multiple ways you can get there. As long as you follow like the basic tenets of maintaining adequate, good IOP throughout the case, making sure the breaks are as properly addressed as possible. There's a lot of ways you can do it. I think that's what makes this a lot of fun. It's like your own little art form that you can play with. Like, what am I gonna create in the OR today? So if anybody has any final tips or things that they think about as we wrap up, but otherwise this was an awesome episode, and thank you so much, David and Mira, for joining us. And hopefully we'll do this again soon.
Thank you, everyone.